I'm recording at any point that you want to start.
So we're going to talk about the approach to 2 centimeter articular cartilage defects of the knee. And anytime any surgeon is focusing on how to treat these, they're all a challenge for all of us. But what we have to do is we have to set a template. And what I call this what the lesion is, who the patient is, what the variables are that will determine success and failure, and we've got to consider all those variables systematically. So the first issue is, what is the lesion? We said it was a 2 centimeter by 2 centimeter chondral defect, not an osteochondral defect, with normal alignment, no malalignment, with no significant meniscus deficiency, and no significant ligamentous deficiency. So basically an isolated articular cartilage defect, 2 by 2 centimeter, 4 centimeters squared, and we're left with answering several questions. What are the other variables that goes with this patient? Is the patient 16 years of age, or are they 32 and this lesion occurred 16 years ago? Is it something that they need to take care of today because they're on a college scholarship? Are they a professional athlete out of contract within the next year or so? So all of these variables have to be defined. The other issues you really have to look at, what are the general medical issues? Who the patient is it a workman's comp case? What's the BMI? How old the patient is? What the other medical issues are. If it's a woman, is she estrogen deficient? Is she perimenopausal? And we go down the list of looking at each of these variables, because each of those become critical determining what the potential prognosis is. Another very important variable that needs to be considered is, what is the time from symptoms to treatment? We have found in any of the articular cartilage repair procedures that the time from symptoms starting to treatment really is actually a negative prognostic factor. In other words, the more time, the worse the prognosis. Age is another variable that's important to consider. And in terms of athletic ability, the higher level athlete will have a better prognosis than the lower level recreational athlete. And lastly, we must consider what we call where they are on the chondropenia scale. Are they normal with respect to generalized articular cartilage degeneration, or are they far down the chondropenia scale and have significant degenerative changes? So what we're really getting to is, it's a multiplicity of variables. It's a complex equation, and we need to consider each one of those in a very specific way. We get to that point, and again, in this case, it's an isolated articular cartilage defect, 4 centimeters squared, and we have to look through the options. So what do we consider? For example, microfracture. For this type of treatment, a 4 centimeters squared lesion is pushing the indications. We know that microfracture is probably better for the younger, the lower BMIs, and the smaller lesions. Another option to consider is osteochondral autograft, mosaioplasty, for this lesion. For a 4 centimeter squared lesion, it would require several plugs, so it becomes a mosaioplasty. And in most situations, too large for an osteochondral autograft overall. Other options at this point in time would include the ACI, or autologous chondrocyte implantation technology, which has been around since 1995. Several studies have been done, including studies in terms of the durability outcome in athletes, specifically of the femoral condyles, with respect to ACL deficiency, as well as in the patellofemoral articulation, all showing significant improvement with respect to baseline. The next set of options we must consider is the osteochondral allograft, usually reserved for the larger, deeper lesions, osteochondral in nature. And some of the good parts is that the osteochondral allograft, the hyaline cartilage, is immune privileged. The big problem with osteochondral allograft is the fact that there's limited accessibility to grafts, and we have long waiting times to get a graft in that particular situation. But that being said, once we get the graft, results have been very good overall. Some of the newer technologies, such as de novo NT meaning natural tissue there's been a lot of excitement, and at this point, it's not under clinical trial, it is clinically available in most places in the United States. And basically, these are particles of cartilage from a young baby, allogeneic particles. And the rationale coming from the ITSO technologies from St. Louis are basically ones where these cells, these fragments, are immune privileged, and they have a very high metabolic activity. Once they're put into the articular cartilage defect, they reproduce and proliferate at a very high rate. Initially, initial reports by Jack Farr and others have shown very good results at this point in time. The next generation of the de novo family is de novo ET. De novo embryonic tissue is under clinical trial at this time with respect to microfracture, and we await new results as we move forward. And lastly, the CASE, cartilage autograft implantation system, a technology that comes out of DePuy Mitech, Johnson & Johnson, a technique where we grind the articular cartilage from a non-weight bearing portion of the joint. We take it, put it on a scaffold made out of PLA and PGA, and with fibrin glue, we then fix it with these bioabsorbable staples. This is presently available in a clinical trial situation with respect, randomized control with respect to microfracture. So, all in all, 2 by 2 centimeter lesion, a significant challenge. We need to define the who's, the what's, the technical details, and then we can make a decision about exactly what we want to do. The other issues are more pragmatic, such as whether or not the payer will consider any of these technologies experimental. In many cases they do. Decision making from one state to another varies in this regard. And then you get to other issues that have to do with finances and economics, the patient's responsibility, the surgery center or hospital's responsibility, and therein lies some of the complex issues that you have to deal with. So, in conclusion, articular cartilage defects, especially ones as big as 2 by 2 centimeter lesions, are complex. They're a challenge for any of us who deal with these things. We have to consider lots of variables. We have to consider gender issues, hormonal issues, alignment, presence of ligamentous deficiency or meniscus deficiency. When we do all of that, we make our plan, our algorithm, and we execute our case. Thank you.